Thank you everybody for coming out. I know there's some sort of like something is happening out there. I know it's quite a struggle to find parking, but I'm Karen Tang. I am local to here. So I live in Marion Station. I was saying I have 3 kids in like all of the lower Marion schools. I got a Marion Elementary School, Ballackin Middle School, and a lower Marion High School. And I'm a gynecologist and a minimally invasive GYN surgeon. And somewhere along the way, pre-pandemic, I started doing social media, which was kind of almost an accident. I didn't know social media before that, and just sort of dipped my toe in just to get people to realize that I was in the area and that I had a practice. And then the pandemic happened, and then everyone was suddenly on TikTok, on Facebook, on Instagram, looking for entertainment or education or facts about health. And the social media kind of blew up a little bit. I think it's a testament to how little information there is about women's health and how difficult it is to find reliable information that you could trust from the medical provider in a way that feels comfortable. People oftentimes are. It's not a natural feeling to go up to your doctor and ask them, I have these questions about my body. Is this normal? I've been wondering about this. No matter how old you are, where you are in the reproductive life. And so, the video really took off, and that led indirectly to the book. It's Not Hysteria, which came out in May. So the subtitle, if you haven't seen the book, is Everything You Need to Know About Your Reproductive Health But We're Never Told. It's a little parentheses. And it basically was my attempt at putting literally everything. If you've ever had a question about, is this normal? I don't know what my choices are. I'm struggling with this and I can't find someone to help me. That you would be able to come to the book and find the answers there. So it's got literally everything. It's divided up into different sections, like, kind of just like the sex ed basic facts, what are, the parts of my body, what makes a period, how does pregnancy happen? And then it goes into different conditions, things like endometriosis, PCOS, PMDD, menopause, perimenopause, huge topic. I think we can spend a lot of time talking about that today. Birth control, hysterectomy, sterilization, and then also things like, what do I do if my doctor's not listening to me? That's such a struggle for so many women. If it was really simple to get all your questions answered and your health taken care of, nobody would be in this room right now. There would be no book. But unfortunately, that's the reality for so many people, is that it's really a struggle. So, there's chapters about, how to advocate for yourself, how do you make the most of your appointment with your doctor, how do you find a specialist. So I didn't want it to be just an encyclopedia where there's just like some dry facts. It's about someone's like lived experience of, having a hard time as a woman in our current society, trying to get the help that you need. We could talk about a whole bunch of things. Like I said, we can keep this really relaxed. Earlier, someone was pointing out the cover. And if you would see this beautiful rainbow, I call it rainbow vulva. It's a vulva, yeah. And I say it also looks like a flame. It looks like from far away, it looks like fire. And so my interpretation, this is not, the artist hasn't told me what he thought when he made it, but my interpretation, fire, it's illuminating, but it's also painful. It also, can burn everything down and start again. And so, it represents kind of, I think, a lot of the things that women go through, in the search for answers about their body. And we were saying that it actually went through quite a few iterations. It didn't look like that in the beginning. It started off with a uterus made of like cotton balls and stuff. It looked like a tampon ad, so we scrapped that one. And then we had one, there's a book called The Garden. I don't know if you've seen it. It's a black cover with a uterus made of flowers. It was beautiful. And we had the same cover. And everyone loved it. We thought it was really cool and kind of like interesting looking. And then we discovered this other book was coming out. We had to scrap it. And then we went through a couple others, and then we landed on this one, which I think is great. So in terms of, like I said, I'm happy to, like, if you guys have questions or things, like I can go on and on forever. Janet, do you want to, like, we can kind of be in conversation. While you're thinking, I can, like I said, I can go through some more.
Okay.
So today's obviously 9/11. I was in medical school in New York from 2000 to 2005. So when I was in medical school, 2 major things happened that affected everyone, not just the people in New York, not just, the people in the US, but affected literally everyone. One was obviously 9/11. I was a second-year medical student. I watched the second tower fall. We had a very high dorm. The dorm was literally a high-rise apartment building, and a whole bunch of the students went up to the top of the dorm, and we actually saw the towers falling. And that just impacted, I think, all of us who were in training at that time, just that experience, that sort of feeling of powerlessness, that we were trying to gain all this knowledge, but really couldn't use it, and feeling that sense of our own limitations. So that really colored my experience as a doctor and a human being. The other thing that happened during medical school during that time was the Women's Health Initiative. So have you heard of this, like the big research study on menopause? So 2002, there was a massive study called Women's Health Initiative that was about hormone replacement therapy. It was a bigger study, but the paper that came out of it that really just changed everything was focused on menopause and HRT. And it showed that there was an increased rate of heart disease, strokes, breast cancer with certain types of HRT. And that completely transformed how women's health was approached in menopause for 20 years. Because before then, people were offered it like, check your bones, it'll help, your vaginal health. But then right after it was like literally like the record scratch sound effect, like screeching halt. People literally had to be like nearly incapacitated with symptoms before we would be giving them hormones. And if we did, we had to have failed everything else, like every other medication you could think of, you had to have failed it before we would consider it, because otherwise it's too dangerous. And to this day, a lot of people, including doctors, if you say the word HRT or hormones or menopausal hormone therapy, the first thing they say, well, but doesn't that cause breast cancer? Doesn't that cause a stroke? And so there's still this sort of stigma around it. Anybody who's been anywhere near social media knows that like menopause is sort of having a moment right now. So women, the Oprahs, the Halle Berrys, these powerful women who finally got to the point of going through menopause themselves are like, this is ridiculous, like this is horrible. Like women throughout all of human history have just sort of dealt with it because in the last 20 years they were told this is too dangerous, like you're gonna give yourself breast cancer, just deal with it, just suck it up. And the last couple of years, people looked at that data again from that study, the Women's Health Initiative study, and they realized that when you actually analyzed it in a more accurate way, the results were much less risk than had been published. Women who are younger in their 40s, 50s had much less risk than, say, somebody who's in their 80s, because they just have less risk of breast cancer and strokes already. So that study had kind of like overestimated the risk of younger women. It didn't look at every type of HRT. There's certain types that are less risk of, patches, things like that. But the risk had been sort of blown up in the media, like it's going to cause your, all this harm. And that then carried on for 20 years. Like the way that like half of the human population was treated and half of the human population is going to go through menopause was colored by one study that happened right when I was doing my third year medical school rotation in OBGYN. So from like literally the first moment that I was in the world of OBGYN until about 20 years later, that's how we were treating women in menopause. And I think it's just sort of emblematic of, all the reasons behind the book, why is it that we do need to like kind of to fight to get more accurate information, better research, more resources, more options for women, is that, like there's so many different things. One, there's just not enough research. The fact that one study could make that sort of impact, like you don't think about that for, like, you don't hear about that for men's health, like for erectile dysfunction. Like there was one study that showed some risk and then they shut down all of Viagra and all that stuff. Like there's no such thing. There's sort of this tendency towards, like hysteria when it comes to women's health and like inflaming women's fears and like, making people feel like, that they play on anxieties. And also, like I said, just if there was better research, there were more research studies, we would be able to kind of point to different studies and different results. But because there was this one big splashy study that so much emphasis was put on it. And I think now that you have your Oprahs and your Halle Berrys talking and speaking out, I say it's the Emperor's New Clothes phenomenon. It's like one person starts talking and then everyone looks around and like, oh my God, I'm having a miserable time too. I didn't realize that I wasn't the only one. So there's such power, I think, in people sharing their stories, being vulnerable, being transparent, and then also saying like together we need to demand better answers, better resources, things like that. So, that was part of my aim in writing the book, trying to get it out there. Anybody who is, an author has written anything knows it's kind of a struggle. And so the reason I get out and I do the social media videos and everything is, I want to get this information out. I want to get those conversations started. Question, yeah.
Sorry, I was just curious, was there any sort of specific moment or catalyst in time, whether it be as a woman experiencing the American healthcare system or as an OBGYN, where you said you came to the conclusion that I need to write a book?
Yeah, so I'd always been more of a writer than a social media person. So it is very ironic that I started doing the videos before I wrote the book. The videos were sort of in the same, like it had the same motivation. It was trying to kind of like, to get information out. I would hear misinformation. I would try and kind of make an educational video debunking those myths. I didn't know how books got published, like, to be honest. Like, I knew books existed. I had no idea how it got from like an idea to, on a bookseller's bookshelf or in the library. A literary agent actually reached out to me because she had seen my social media posts and was like, I think this would make a great book. And then I had to find out what all that meant, like what's an agent, like, how does he, and then I ended up with a different agent, but we put together a book proposal because like I knew that there was such a need for this. Like I had seen this, and every time I make a video, I would get like 100 comments being like, well, do you have a video on PCOS? If I talked about endometriosis, like, well, can you talk about PMDD? Can you talk about birth control? So there was always like, even if I made like a video about one topic, there would always be so many other topics that people would then have to like search and find, like, so having a resource where everything is one place was sort of the dream. And so I was very fortunate, kind of just like I said before, anybody who's a writer knows that this is not, it is a huge, huge feat. And a great privilege to be able to publish a book, a traditional Big Five publisher, to have it in libraries around the world, to have it in bookstores around the world. I just went to England, and they had it in like Waterstones and foils, and that was like outrageous, so cool. But yeah, no, if you told me like a couple of years ago, like, would I write a book, and I'm like, come on, no, there's no way. So it sort of, it came across my path because I had the platform and people saw that there was great need. So that's pretty much.
Thank you.
Thank you for being here.
Are you still,
Yeah.
I'm sorry, are you still practicing
I
medicine?
am, yeah. So I just opened a practice. It's in Bryn Mawr. It's called Thrive Gynecology. So it's just me and my nurse. We are a very small, like, out of network practice because I take care of people with chronic pelvic pain, endometriosis, menopause who need a lot of time. So my appointments take like an hour. So if anybody needs gynecologist, please come see me afterwards. I'd love to see you. So like, the office is in Bryn Mawr. It's right, behind Bryn Mawr Hospital. A very lovely, welcoming space. So.
So personally, in the chapter on endometriosis, I actually wrote this book while I was recovering from surgery.
Oh my gosh.
So kind of just interesting timing. But I find that like so much of my information did come from social media and other places like that. And I found that, I'm 41 years old. My experience is very different than somebody who's 22. I was not in the position of trying to preserve fertility or anything like that. But I find that the conversations between those of us in our 40s and those of us in our 20s with the same condition is very, very different. And even with my own doctor, the first instinct was to treat me like I was 22 years old and trying to preserve my fertility. So how do you, or advice for other people in having those conversations, approach that subject without being like, no babies, let's do this that way, having to wear the flag so openly.
Yeah, and that's actually one of the first chapters is sort of like a taking stock of yourself. Like, it's literally like, what symptoms are you going through, but not just that, what is your perspective? So it actually asks about things like fertility. Is it, are you somebody who, is planning to get pregnant, wouldn't mind if you got pregnant sometime, but it's not something you're planning on, is absolutely sure you don't want to have children, because obviously that completely changes your approach to the treatments. And that's actually why, in theory, your gynecologist, when they talk to you about options, should be asking those questions, be like, what are your thoughts? In a very non-judgmental way, just be like, what are your thoughts? Is this something that factors in? Because there is an assumption, and I say it there, there's chapters on abortion, chapters on sterilization, chapters on hysterectomy. A lot of times people who are looking for sterilization tubes, hysterectomies, sort of find that they face a lot of resistance from some doctors because they're like, well, but you might want to have a baby later. You're like, I've had patients who are like 40 who had children and they are told, but you might want to have more children. They're like, I can tell you, I know I do not. And so part of the problem is sort of this idea that if you had the biological potential to become pregnant and carry children, that you will want to. So that is a problem in and of itself, is sort of that expectation.
And then just one follow-up on that. Is there any kind of, so my gynecologist is a gynecologist, so I guess I assume she knows everything about everything. Is there any special training for specific conditions that doctors, gynecologists go through? Like, is there a special class on endometriosis?
Yeah, so
Fibroids?
I specialize in endometriosis, and so it's actually a fellowship. So we actually have a couple of gynecologists here. So we have fertility specialist, Dr. Lee, who is actually my expert. She is my expert reader on the infertility and miscarriage chapters. So thank you for your expertise. And we have OBGYNs, and so there is extra training in endometriosis because the surgical management is very difficult. And that's partly why people kind of end up in the pattern sometimes of like they get tried on 80 different birth controls because the doctor doesn't want to take them to surgery because sometimes it's really hard surgery. So sometimes you have to see someone who's a specialist. So for menopause, sometimes people need to see a menopause specialist. For fertility and fertility, you definitely need to see a specialist. So all of us go through after medical school 4 years of OB/GYN residency, but then you can subspecialize. The other specialties are like oncology and urogynecology, which is like incontinence and prolapse. So a lot of people, and things like, frequent UTIs, bladder issues, that sort of thing. So there are subspecialists. If you feel like you're talking to your gynecologist and you're not really kind of getting options, then that's where you start to look for somebody who's more subspecialized. So to say that in the book as well is, toward the end chapters, what do I do if my doctor's not listening? Or they're telling you that's normal, that's it. In anything in medicine, it should never be, that's it. You have no options, no next step, nothing. There should always be a what's next. So, Dr. Wax knows this. There should be are we doing some sort of testing to figure out what's going on? What options can I try to help my symptoms? What is the role of things like surgery? So there's not one size fits all, but they should be telling you things. So they should be presenting those to you, which a lot of times people don't. And I always tell people, if you have like kind of limited options, not here, fortunately, we're very lucky, but I have followers who are like in rural someplace where they have like one OB/GYN, there's no one else that they can see. You can kind of push back a little bit, be like, so what do you think is going on? Like, number one, what do you think is going on? What can I do next? If you have no more options for me, can you refer me to somebody else who can? All of us refer to lots of specialists. I send people to, GI doctors, urogynecologists, pelvic floor physical therapists, fertility doctors, all sorts of specialists. Like, I'm not planning to do every single thing. And so if they can't give you those options themselves, they should be helping you find someone who is. The endometriosis has become a situation where support groups on social media have had to do this themselves because they have such a hard time finding specialists. So there are big groups like Nancy's Nook that they publish surgeon lists, or they talk amongst themselves, like, I'm in Delaware, like, can you recommend a doctor? So a lot of times people are using those social networks to crowdsource, who had a good experience. A lot of patients find me through just word of mouth. And so, who did you have a good experience with? Who listened? Who was able to do the surgery? Who, was very understanding and didn't judge? The tubal ligation thing, there is I don't know if anybody knows this, there is a Reddit, a group that is almost 2 million members that is called the child-free subreddit. And it's literally people who've been trying to get a sterilization who are child-free, who couldn't. And they published a directory of doctors in every state. And after Roe v. Wade, I will tell you, I had 50 calls a day from that group. So people were coming from all around. Like, I had people come from Florida, from Georgia, like literally because they're like, I need to get my tubes tied. Everyone I see locally is telling me you're going to want to have kids, you're going to change your mind, or you have to have like 4 children before I can tie your tubes. And so people literally were like, and they found themselves on the subreddit, and then they would find doctors through that group. So, and this is just like, healthcare in 2024 is that if you can't find local help, like, people are tapping into resources online to find help for themselves, which is great.
I ended up changing jobs to have a better insurance plan to be able to have surgery, because it just, otherwise was not feasible, and you find yourself looking everywhere, anywhere.
Yeah.
For somebody who will do this for you. So I do feel for the younger crew going for this, but I do think as an older woman, air quotes, that I feel like there's a lot of screaming from the mountaintops of the younger group. And I feel like they could use a little older voices to say, let's whisper in the ears of those that can make change.
Yeah.
And trying to figure out how to fit in to that world. So I've tried the support group thing and I was like, I am officially the oldest person. So, you know, it's just very different in some things. So I think even within the same, you know, to see these your like opposite ends of experience as well.
But it's helpful. I tell people a lot of times I give these talks and it gets very depressing. Everyone's like, oh, this is so good, you know, like women's health is horrible. But I try and kind of like swing it to sort of a more positive, proactive lens, and that I tell people you have a sphere of influence no matter where you are, and your experience, the things that you've learned about the process, you know, you can help someone else. Whether that's in your community, in one of these social media groups, you know, it just literally among friends. Sometimes I had a lot of people start groups or discussions and stuff like that in their workplace. Like they'll do like a women's book club or something like that, just to kind of get the conversation started. So there's some way that you, using your story and all of the hard-won knowledge that you got through this whole crazy process, can help make, you know, smooth the path for someone who's younger, who doesn't even know what it takes to find a doctor's appointment, let alone a specialist, let alone navigate the insurance system. You know, that there's some way that you can kind of contribute and make the world a better place. And one of the things that I am most honored by is when I get messages, people saying, I bought the book for my daughter, because I had to fight like my butt off to get care, and I don't want my daughter to have to do the same thing. I wanted to kind of start off as a teenager in, you know, college, already knowing like her body, understanding what could be going on, understanding options like birth control and, you know, endometriosis and surgery and all this stuff, so that they don't have to reinvent the wheel every single generation to, you know, to like, how do I find a doctor who listens? You know, it shouldn't be that hard. It should be something that we like improve over time, and that the next generation has it a little bit easier than we did.
That's the goal. It's done.
As we
Can you tell us a little bit about PCOS?
Yes, yeah.
I, as a pediatrician,
Yeah.
did a fair amount of diagnosing of PCOS.
Yeah.
And a lot of referrals to gynecologists of teenagers with. But tell us a little.
Yeah, people have heard of PCOS. Yeah. So-
I actually don't know what it is.
Oh, yeah, I was about to say,
I'm
I'll
sorry,
start from
sound
scratch.
ignorant.
Yeah, so polycystic ovarian syndrome is actually the most common endocrine condition of reproductive age women. A lot of people don't know that. So it is a group of symptoms. So I'm like gonna try to get this right, as Dr. Lee is an expert, but so it is not one disease. It's not like there's one gene, one enzyme or something. It's just a cluster of symptoms. So basically, to be called polycystic ovarian syndrome, we have to have 2 out of 3 things. So one is polycystic ovaries on ultrasound, which are not like huge cysts. People picture like massive cysts. They're actually really teeny tiny. It's basically just follicles or where the eggs are developing. People with PCOS oftentimes don't ovulate regularly, so you get a lot of little follicles kind of waiting to be released, and so you can see them on ultrasound. It looks like a little string of pearls. The second is that because they don't ovulate regularly, they don't have periods regularly, so you may skip a bunch of months of periods, so like missing periods. And the third is they tend to have, you know, signs of too much testosterone, so they can have like facial hair, acne, things like that. So the 2 out of 3 things, you have PCOS, and obviously we make sure there's not something else going on, like, you know, some other strange condition. There's rare conditions that can cause the high testosterone. So it very commonly presents as like a teenager missing a bunch of periods, maybe really struggling with acne or like kind of having to shave and things like that. And a lot of people who are teenagers have irregular periods, so they kind of may not necessarily get a diagnosis right away. People are like, oh, every teenager has missing periods, but they're like, it's been missing for 6 months. It's also a common cause of infertility, because if you don't release an egg regularly, you can't get pregnant. So it's a common cause of you know, having difficulty conceiving. So I say in the chapter on PCOS, it is a very confusing condition, because you can have PCOS and not have polycystic ovaries. Because if you have the other 2, you don't have to have polycystic ovaries to be called PCOS. So it's like a poorly named condition. And that people with the same PCOS can have completely different symptoms. So people, it can be associated with being overweight. But you can be slim and have PCOS. You know, you can have more of the facial hair thing and none of the other issues. People have a high incidence of diabetes and what we call metabolic problems like diabetes, high cholesterol, high blood pressure, even if you are not overweight. So it's not just a hormone issue, it's also, it kind of affects all of someone's life. Like someone can be slim, eating perfectly, and still discover that they're diabetic if they have PCOS. So the management is very complicated. So I mentioned in the book that involves your primary care doctor, your pediatrician, maybe an endocrinologist, fertility specialist, you know, looking at what you're eating, making sure that, you know, we're not like we're taking care of things like high cholesterol, we're taking care of your fertility. If you're missing a bunch of period, there's also some other health risks for your uterus. So it's a complicated issue. And so it comes up a lot in the pediatrician's office because it very commonly affects teenagers. So before someone's even seeing a gynecologist, they may be seeing a pediatrician. Endometriosis too, I will say endometriosis, oftentimes the school nurse, a primary care pediatrician, or a GI doctor, because a lot of times it shows up as really bad bowel problems. So diarrhea, constipation, bloating, nausea, vomiting. Someone may have gotten used to having horribly painful periods and just like, well, I guess I just always have horribly painful periods, but they're like, I can't deal with this diarrhea. So they may see a GI doctor before they see a gynecologist. So a lot of this, the problems of the missing diagnoses and struggling for years and years is partly because, you know, sometimes there's so much normalization of women's suffering that like, they're like, that's just lady stuff and you're, you know, debilitating pain or your periods are all wonky, but, you know, like diabetes is a real medical problem and, you know, bowel problems are, you know, something tangible that we can, you know, do a huge workup for. So anyway, it was a good point about non-gynecologists being the ones who oftentimes diagnose some of these GYN issues.
Can you talk a little bit, this is a different subject, of your process of what you didn't put in the book?
Oh.
How you decided not to, and also
That's a great question.
how you deal with the hate mail and tutors that you get?
Yes. Oh, also a good question. So I don't practice obstetrics. So in the process of subspecializing after my training, I gave up the prenatal care and delivering babies. So I say in the book that there's only so much you can put into one book. Like it would be like a whole encyclopedia series if I tried to put everything about pregnancy, childbirth, postpartum. So, you know, I knew right off the bat I wasn't going to include all of that. I was going to kind of focus on what we call like the gynecology aspect of things. And that was just sort of, you know, knowing that I had to understand my own limits. And the amount of detail in the book too, I wanted to make sure that it wasn't too overwhelming. I try not to read reviews, but I sometimes will peek at the Goodreads reviews, and it's very funny because like you'll see one be like, "Well, I already knew everything in this book." I'm like, "You really?" I'm like, "I learned things in the process of reading the book." So I'll see these reviews. They'll be like, "I already knew everything in this book." I'm like, "I don't know if you did," but I didn't want it to be too full of research studies. I didn't want it to be like every research study about a topic because I would get just too overwhelming. So I tried to kind of like to synthesize it and to process it and kind of put, you know, the information. And with that, knowing that there's going to need to be future generations of the book that will be like updated as we learn more about certain things. And the hate mail question. So I do a lot of talking about reproductive rights because in, you know, my friend Jess, who was also on social media, before a few years ago, I think a lot of us tried to be apolitical in public spaces because we didn't want to make it seem like we were biased, you know, that we would not take care of someone of a certain, like, you know, political party. But obviously reproductive rights are on ballots now, are being determined by politicians, people with no medical background who oftentimes get it wrong when it comes to facts about things like abortion, gender affirming care, IVF, that sort of thing. So, you know, being experts, you know, I think a lot of us now are speaking out. A lot of fertility doctors have gotten very public on social media. They formed nonprofit groups to advocate for, you know, protecting IVF, protecting access to abortion. You know, IVF and abortion and embryos are all tied together. So I obviously get, a fair number of comments about people who are like, you're murdering babies. I don't perform abortions, but obviously I feel like people should have the right to choose for their own, their own situation. And I just ignore them, I block them. I literally protect my mental health and knowing I'm a human being. And so if I see, I'm like, oh, deleted, blocked, it's my account. I can filter it as I see fit. And sometimes I'll leave things on there if it's a point of discussion. If it's somebody who's like genuinely like, well, actually I heard this and I thought, if there's something to be learned, to be gained from people kind of like having a conversation, but if it's just like over harassment, that sort of thing, like, so just what do you?
Yeah, not in on, yeah.
Yeah, exactly. Like, we don't tolerate it anymore. I think too, so many of us, we're women, we're used to kind of being like, well, like, we don't want to insult anybody, or like, I think we've gotten to the point where we're like, no, bye, deleted. Yeah, it's tough. And sometimes it's people who you could tell, like, just they feel really strongly, they feel like, they're like, they're saying their piece, and I'm like, that's great, but you don't get to go on someone else's social media and like say horrible, abusive things. So deleted, blocked, all that stuff. Yeah.
I manage healthcare benefits at Comcast.
Oh,
We're implementing progeny for family forming benefits next
Nice.
year, and we've been talking with committee for menopause support. Any other recommendations? We get so many requests for resources.
Yes.
Nowhere.
absolutely. And have me come talk or something, because like this is a huge issue. Like people realizing that both in terms of recruiting women in the peak of their careers who are also dealing with period problems, fertility issues, and menopause. That is like your peak, like your talent. And if you're gonna lose them because, like say they have endometriosis, they're missing all sorts of work. They can't come to work because they're in too much pain, or, they, are struggling to get benefits for IVF. I think a lot of the big companies now are offering like IVF, egg freezing is huge. Allows people, if they're really focused on their career, to have that insurance benefit to, like to freeze their eggs so that later on, if they want to have a family, they won't feel like they've kind of like missed their window. And then, yeah, menopause, people who are truly at the peak of their careers, a lot of times like women are dropping out of the workforce, like they're so, they can't focus, they're having brain fog, they can't sleep, they're, literally they're so hot that they can't like, kind of pay attention. So there are a lot of things, like, I think those are probably the big categories. So the fertility benefits, education about things like endometriosis and fibroids that can be causing absenteeism that, there are treatments for, that oftentimes the treatments, the relief is delayed by many years. On average for endometriosis is 7 years before someone, between symptoms and getting treatment, which is crazy. But yeah, for those 7 years, they're like missing work. Like I have patients who are like, I miss like at least 2 days of work, like every single month, because I just can't handle it. So things like that, actually overall, like can really impact your workforce. And then the fertility, I think, is a big, not calling card, what would you call it? Like, yeah, like it's a something that's pretty amazing and makes you stand out as like an employer. And then also, like I said, having some of these lunch and learns. I know a lot of different big companies now, like they'll have like women's book clubs or women's discussion groups. They'll bring in a specialist to just talk with everybody about menopause and things, and just feeling like, oh my gosh, like I can talk openly about that. I don't have to hide it. It makes a big difference in feeling valued and feeling like seen and feeling like your needs are being met. So that's great. I love it. I've done a couple of book clubs for big companies where I'm just like, thank you for treating your employees like human beings.
So how did menopause become such a taboo topic? Why has it been so shameful to talk about for so long?
Yeah, and like, and I would love to hear what people have been told, because like
Nothing.
Okay,
That-
I was about to say
nothing,
nothing.
yeah.
So, and again, half of the human population, it's not like this is a rare niche topic. It's like literally half of humans are gonna go through this at some point. And I think, like I said, it all comes down to that normalization of suffering, that they're like, every woman in all of human history has just dealt with this, or else they died early, like, you know, life expectancy,
Right.
like you died before you went through menopause, you died in childbirth. So, just like all women, you know, if you survived, made it through menopause, that you just dealt with it because there was no treatments, and that just became, that was the norm. And like I said, then you added the Women's Health Initiative, because for a while, before the WHI, it actually was common for people to get put on HRT for almost like frivolous reasons. They're like, oh, keep you like your skin youthful and it, you know, help your libido, which it does. But like it was almost like too cavalier. They're like, just put them on HRT. Like they didn't get a whole lot of talking and education. It was just sort of like, here, take this prescription. So, you know, once the study came out, it then became, well, let's just strip away that one thing that you guys got. And then it didn't get replaced with education or resources, or what do you do instead? Or what about exercise? What about nutrition? It was just like, well, you just don't get that anymore. So, and I have a whole chapter in the book at the very beginning on history, because one, I think history is fascinating. I actually use some of the books that are out there on the table, like on women, because I think there's a context. It's not that all of this happened out of nowhere. There's a social context about how women have been treated, and health has been seen for all of human history. And like I said, it's just a normalization of like, well, you know, like that's just what ladies do, and it's embarrassing. It's like you don't talk about it. My husband recently had like a pinched nerve, and he had to go get physical therapy, and he could tell everyone. He told his employer, he told his colleagues, like, oh, I pinched my nerve, my leg hurts, I got to go to PT. But God forbid some woman who has like, I'm bleeding a lot, or I have my bladder's falling. Like, you know, you'd be like, oh my God, I have bladder prolapse, and I'm going to see a urogynecologist and physical therapist. Like, no one would feel comfortable saying that, but we should feel comfortable saying that. It's just healthcare. So, you know, right from the beginning, and I think this is part of our culture. It's, you know, how the medical system sees us, because doctors and all other health providers are human beings that have absorbed some of this. I hear all the time from people like that, you know, children, like their kids were, oh, like called the principal and said, you know, your daughter said a bad word. She's like, you know, just from the beginning, it's dirty, it's embarrassing, don't talk about it, periods, you know, the whole tampon Tim thing, and like talking about tampons is like an insult. Like, you know, oh, you're on your period, you're PMSing, it's an insult. So right from like when people are teenagers, they absorb this message. Don't talk about it. It's gross. It's embarrassing. You have to keep it to yourself. And so, you know, that gets internalized, and that then in turn, people don't fight for research and funding. They're like, well, we need more funding for our prolapsing bladders. Like, you know, people feel embarrassed to do that. Whereas heart disease, cancer, everyone will go out and run a race for cancer. Everyone feels like cancer is important. It's true, it's important, but the point is, you know, like quality of life is important too. And, you know, for people to feel like, oh my God, no one's gonna like make a race for like, you know, vaginitis or, or, you know, it should be that we can talk about these things. But that's part of the reason that we don't get the funding. And that now we have the Oprahs and Halle Berrys like lobbying on Capitol Hill. Halle Berry literally went to Capitol Hill and led like a bipartisan like bill on menopause funding, because she's like, I had vaginal pain, and my doctor misdiagnosed me with herpes. Said your burning vaginal pain was herpes. It was not. She told her story very openly. She was like, it was not herpes, it was menopause. And she was like, this is crazy that women are treated this way, and that we can't even get answers about our bodies. And so she literally was like, we need like funding, we need education, like all this stuff. So now this is where menopause like is having a moment, because women in power with a platform are finally saying like, this is crazy. Like, why have we suffered like this? We don't deserve to suffer like this. So I think it's going to take endometriosis. You have a lot of celebrities who have spoken out about, you know, like Chrissy Teigen and like Olivia Colman, like all these people again who are wonderful speakers who are like, I was passed, you know, from doctor to doctor. I said 10 doctors finally had surgery after X number of years and discovered that it was endometriosis. So this is, you have women who finally have the ear of the public, and, you know, start to kind of, again, you get the emperor's new clothes effect, and then people start to kind of rise up and band together and demand better.
I think it's fascinating that, I mean, say, for example, 25 people in this room say we were all going through it, but nobody really compares notes. So you
Yep.
don't know, is this normal? Is this abnormal?
Yep.
Do you have this? And it, like, does anybody know the complete list of possibilities? Because nobody discusses it enough.
Yeah. I can't tell you how many friends I've had who, when I tell them what I specialize in, will be like, oh my God, I have every one of those symptoms. And I'm like, you probably have endometriosis. And like, they're like, oh, I just dealt with it. I'm 40 something. For 20 years, I just kind of sucked it up and I took a million ibuprofen every month. And so I was like, and again, like, because it's not kind of day-to-day conversation, but we should make it that. That's, part of the reason, again, I wrote the book was I wanted to be like, discuss it in book clubs, like tell your friend, be like, I'm reading this book and, I've been having this issue and a lot of women have this issue of discovering and it's so common. And, I wrote a letter to booksellers and librarians that I gave to my publisher. They never gave to any. I was like, oh, this is gonna be so, please send this to, booksellers and librarians. This is the mission of the book. And they didn't send it to anybody. And I was so disappointed. But it was basically saying, whenever you see your readers that they're walking around the library, they're women, they're girls, they're going through something in this book. I can guarantee that. Like, they're having, they've had vaginal problems, period issues, questions about their fertility, they've had infertility problems, they're having menopause. They don't know what birth control to choose. They are having some issue in there. They're just not going to come up to you, a librarian, and be like, I need a book on bladder prolapse. Again, they're not going to say it because you're a stranger, they're going to be embarrassed, but they need this information. So this is the idea, is like that you could have it somewhere where people could like, oh, everything you need to know about your reproductive health, I need that. And it's just as important as, any other book, and even more so because it's so hard to get this information. It's hard, like heart disease, diabetes, like there's not that stigma attached, where it may be a little bit more comfortable to, ask a friend, ask like, even just your doctor to have that conversation.
So question, do you have any advice for those people who have been diagnosed with PMDD?
Yes, yeah, PMDD is a tough one, and premenstrual dysphoric disorder, for those who don't know, PMS is, you have some moodiness, you have some bloating, some breast tenderness. PMDD is where you have the physical symptoms, but you have extreme emotional symptoms. So depression, anxiety, panic attacks, anger, to the point it's affecting your quality of life. And again, I can't tell you how many women are in my office for just like other visits, like routine visits, and I'll ask about symptoms. And I'm like, that's PMDD, right? Like, that's not just normal PMS. And they're like, oh my gosh. So people who are like, they can't work, it's affecting their marriage. And it's only the 1 to 2 weeks before their period, like clockwork. And then as soon as your period comes, it's over. So that is classic PMDD. It's difficult to treat, but we oftentimes, the gynecology perspective, we put them on continuous birth control so you don't get the ups and downs. So we're trying to prevent ovulation, which causes this. I just made a video about this on social media. It prevents the spikes and the lows. And so you're a little bit more even. And then seeing a mental health professional, like working with cognitive behavioral therapy, and then also antidepressants only during that time. It's one of the few things in just, you don't have to take it every single day if you don't want to. So you can just take it during the weeks that you have symptoms if you want to minimize like side effects and things.
So what antidepressant would you use that didn't have to build up in your system?
Oh, it's any of them. So SSRI. So like there's lots of research papers on it. It's literally, it can be just cyclic, as opposed to like, normally in antidepressants, you have to take it for some number of weeks or months for it to be effective. This is one of the only things you could be like, I just need it for a week. It's sometimes for really severe cases, you do have to take it every day. But again, we kind of balance. Sometimes people have side effects from the antidepressants. They don't want to take it every single day.
Wait, I'm so sorry. Just to make sure I heard you properly, you said for PMDD, during that one period of time before the start of the menstrual cycle, we're talking like taking Prozac, right, for that period of time.
Yeah, just for like that. Yeah, just for like 1 to 2 weeks. I know, because normally you have to build it up and you have to be on it every single day to kind of maintain it. But they've actually done studies where they just did it. It's not as effective perhaps, than taking it every single day. But for people, like I said, you have to walk the balance between, sometimes people get like a little bit of like lower libido or like other side effects from antidepressants.
Do you have a better handle nowadays on menstrual cramps? I mean, this is in my history, but the menstrual cramps were hideous and nothing more. They would say Motrin did nothing, and for 4 hours, every month, I would be,
Yeah, I mean, that's what I was saying, it's like probably with endometriosis, yeah. So endometriosis is diagnosed surgically, so a lot of people just didn't get diagnosed. I will tell you, I should have done a study on this. After the Roe v. Wade, when I was doing 1 million tubules, like I was doing tubules like crazy, I found endometriosis in most of those patients. And I started asking when people came in for their tubal, consult, do you have a history of bad periods? Like, was it really painful? Did you have like diarrhea, bloating, whatever? And like, oh yeah, but I was on birth control. They put me on birth control when I was a teenager to stop the cramps. And I just stayed on it for contraception until I got my tubal. And it suppressed it enough that they dysfunctioned. And they never ended up getting a surgical diagnosis. So all of those women who had really bad painful periods, they're teenagers, they're missing school, they were throwing up, had endometriosis, never got diagnosed. Because it doesn't
Does
show up.
everyone know what endometriosis?
Oh, yeah. Oh, sorry. So endometriosis is a condition where tissue that looks like the tissue that grows inside your uterus, that comes out like menstrual blood, grows outside. So it grows commonly between your uterus and your rectum, on the walls of your pelvis, near your bladder. So it causes really severe pain with periods, pain with sex, bowel problems with your period. So that's what I was saying, like the diarrhea, constipation, bloating, vomiting with your period. I don't know if you're, like if you had any of those symptoms too, but it's very common. It's probably one of the more common causes of severe pain with periods. So if someone, it's very common for teenagers to just have bad periods and they kind of outgrow it. So not everybody with painful periods does, but if you were like, it wasn't just when I was 13, it was when I was like 20s, 30s, 40s, always had painful periods, that's possible. Fibroids show up a little bit later in like the 20s to 50s. And there's something called abnormalities, which is, I call it a cousin of endometriosis, except it grows in your uterine muscle. So there's a lot of different things. A lot of times it's just that people had a condition, just never got diagnosed. And so, again, it's so normalized. That's just periods, that's just cramps. But you're like, I'm missing school, I'm like throwing up, I'm having to take a ton of ibuprofen just to function. That's not normal. So that's one of my messages on social media is severe period pain is not normal. It might be common. A lot of people have it, but it's not just cramps.
Can you talk a little bit about pelvic health? Pelvic
Floor, yes.
and the importance of it? 'Cause
Yes.
I feel like I used to think it was just Pilates
Yeah.
or Kegels, and now
Yeah. Everyone just heard of Kegels, yes.
Yeah, and now I'm like, but what actually is?
Yeah. So I will tell you, pelvic floor, when I was a resident, I finished my residency in 2009, did not even know what pelvic floor physical therapy was. I had never heard of it. I did my fellowship, which again was a pain fellowship. It was, like endometriosis, management of pelvic pain. And one of my attendings quizzed me and he was like, well, if you have a patient with, these certain symptoms, and like he was trying to get me to say, send her for physical therapy. And I was like, what? And he's like, physical therapy, pelvic floor. And ever since then, I find pelvic floor issues in most of my patients. So if it wasn't like, endometriosis inflaming your pelvic floor, causing it to seize up, just being pregnant, ever having a pregnancy or ever giving birth, even if you have a C-section, it strains your pelvic floor. So the muscles in your pelvis, the sphincters and things that are around like your urethra, the muscle around your rectum and the bladder, they all can either become too tight and dysfunctional, or they can be, not coordinated in a way that allows you to, have bowel movements to empty your bladder fully. So very common, in fact, in France, I wrote in the book, every woman after they give birth is sent for pelvic therapy to prevent the incontinence, like the leaking, the prolapse, which is amazing. Prevention, not easy. So rather than waiting until you're like, I'm leaking every time I go running, to early on help to strengthen the pelvic floor. Yeah. So, and then I will also say, Kegels are sometimes counterproductive. Sometimes the pelvic floor is actually too tight and you're not able to control things because it's too seized up and you can't control it. So sometimes if people are doing Kegels, it actually might make it worse, or it can cause pain, because it's just like having a back spasm. If your muscles all seized up, like you might have more pain because of it. So for that reason, I send people for physical therapy so they can guide you. So very important. So I always list a whole bunch of different symptoms and everybody goes like, oh my God, all of the symptoms. So if you've ever been pregnant or ever given birth, like, the leaking with coughing, sneezing with exercise, the bladder urgency that you get when you are in perimenopause or menopause, urgency, frequency, constipation. A lot of people don't realize that chronic constipation, if you're straining, if you have to take a lot of stuff to have bowel movement and you've had that for a long time, that can be your pelvic floor. And also pain with sex. Pain with sex, if you have pain with sex, I'm sending you for physical therapy. Even if it's from endometriosis, even if it's from vulvodynia, they help with that too. So if you have any of those symptoms, pelvic physical therapists can be helpful. So there's a whole chapter on it in the book. A lot of people didn't even know that there was such a thing as a pelvic floor. So just knowing that there are muscles and there's feeling for it. You've been waiting so patiently, thank you.
Thank you very much, yeah. So as I'm listening, I'm just reliving my own kind of perception around feeling like I should just be resigned to perimenopause. I'm thinking about it in a way of I shouldn't have any kind of intervention because it's a normal, inevitable thing.
Yeah.
So I'm just kind of uncovering that, but I'm thinking about it too in a way of, well, should I? I mean, I think I have hopefully a misconception that if I were to intervene, if I were to do some kind of therapeutic intervention, like hormones, that it would actually delay some kind of inevitable conclusion. Is that the case, that there is any disruption when you're kind of intervening with either perimenopause?
No,
symptoms
yeah,
that you-
it's happening. So like to kind of give the example on the other end of the spectrum, sometimes people worry about, is it too early to start birth control for like adolescents who are having painful periods? So we sort of say like, if they've already gone through puberty, like everything is sort of gone through the motions, so you're not gonna like disrupt like something that should be happening. With perimenopause, menopause, it's happening no matter what. Like you're not gonna kind of alter in a dangerous way what was going to happen. Yeah, so the menopause, perimenopause treatment is for quality of life. Part of it's for quality of life, for the sleep disturbance, the brain fog, the focus, like the waking, kind of central waking, the low libido, the hot flashes, the night sweats, which are very disturbing. Like people are like, oh, it's just a little hot. No, like I haven't been through it, but from people who have told me, they've been like, it's not just you feel a little hot. You're like, it's like oppressive. Like you literally feel like you're being tortured. So, those are things you don't have to just suffer through. Like again, it became this thing where that's just normal for women. It's not. So a lot of times I get the question, well, when do you know that you do need treatment for something? Like what's too much pain with periods? What's too much bleeding? What's too much, bad menopause symptoms? It's if it's affecting your quality of life. So if it's keeping you from doing what you want to do in your life, going to work, exercising, having sex, like whatever it is that you're like, I need to do this to feel like I'm living how I want to live, that's when you intervene. So if you've gotten to that point, like if you're just like, I just feel like a little like sweaty at night, but it doesn't bother me, you don't have to treat it. But if you are getting to the point where, things are really throwing you off and it's keeping you from, functioning, from exercising, like definitely talk to your doctor. And there's a lot of different treatments too. As we talk about HRT a lot, but there's a whole range of different things.
And you're not pushing out the end of it, but.
No.
Okay,
No.
thank you.
Yeah. And then people mostly have symptoms, I will mention, when you're in perimenopause, like things haven't completely stopped yet, but your periods you're starting to miss your periods, like your periods haven't totally finished. Like that's actually oftentimes the time that people are feeling the worst. So, sometimes like when it is over, you're like, actually okay. So yeah, it's not gonna like delay the end or push it out or spread it out.
So you probably heard an audible gasp just now when you mentioned France.
What's that? Oh yeah, France, yeah. Yeah.
Give us an idea of what else we American women are missing out on.
Oh, let me tell you. I will tell you. So there's a UK version of the book. I have a different publisher. It was almost like I had to translate it into NHS UK because the healthcare systems are so different. So menopause. I have a friend who is a physician in the UK and she is a menopause specialist. And when I tell you, I gasped many times when she told me vaginal estrogen's over the counter over there and it's covered by their NHS for free. HRT is completely free. And birth control you can get not just from your doctor, you can get it at the pharmacist. They have birth control clinics. You could just walk in, it's just like there's Planned Parenthoods, but there are like many more of them. And so there's not some of the hurdles to getting care like that, you know, like teenagers here are like, oh God, like where can I go? There may not be a Planned Parenthood. And abortion care, much more like straightforward. Obviously, they have different laws. Gender affirming care, even I was very surprised about this. They're like, it's actually, you know, they have fewer centers, but there's less of a hurdle to it. So they had to fight, I think, for the menopause, the HRT. So they did have to do a lot of lobbying for it, but because she said it's a smaller country, there's less red tape. So they said it just took a couple of doctors being like, this is important, you should cover it fully. And they're like, okay, we should. And they did. And I was like, are you serious? So, you know, Dr. Gutt will tell you, like, you know, and Dr. Lee, for us to prescribe HRT, it's not just here's a prescription. It's like a game. You're like, you have to be like, go on GoodRx, look up the coupon cards. We wait and see what your insurance says. Maybe they'll cover it, maybe they won't. Maybe they'll send us a list of other things that they will cover, but then we have to tell you why it's different than what we prescribed. You know, forget it. It's like a whole like
Letter of medical necessity.
you have to like sometimes write letters. Like it is insane. It is like again, if this was for men, forget. I make this case for social media a lot. If this affected men, and you know, made their penis dry up, and you know, they couldn't go to work, they were like couldn't focus, like it would be covered everywhere. It would, you know, endometriosis, if it gave you debilitating pain, you're throwing up, it gave you diarrhea, and they, you know, like caused infertility. We would know what caused it. Like there'd be a million specialists. It would be covered by insurance, like reimbursed amazingly. Like instead, you know, like women like a.
Sarah, could I make a comment?
Oh yeah, please, yes.
I think one thing that is a defect or weakness in our system is that it's very clear for a lot of things. If you have a heart problem, you go to cardiologist. If you have a kidney problem, you go to nephrologist, right? Even if you have an orthopedic problem, you go, and Rockman has an ankle guy, a wrist guy, a hand guy, a hip guy, right?
And also from here to the shoulder.
So it's very clear.
Oh, yeah.
Where do I find this care? But for a lot of these issues that you hit on, PCOS, endometriosis, menopause, it's kind of an overlap because some endocrinologists will treat PCOS, some won't. Some reproductive endocrinologists will treat it, some only do fertility and IVF. So it's not like the patient knows what
Where to
kind of
go.
doctor do I go to address my specific problem. So I think that's really empowering when you're telling patients, well, these are the resources that you can go. You can go to PCOS support, you can go to, you know, the menopause society, whatever. And so you can find a list of people that actually address your issue, because they all might have OBGYN after their name.
Yeah.
But they're not all the same in their area of what they do.
Yeah, exactly. And I say in the book too, it's like a system problem because, you know, like kind of starting from like insurance coverage for women's health is horrible. I say in the book, literally everything in women's health, the equivalent in urology is reimbursed at a higher rate.
Yeah.
Everything, prostate biopsy, like you know, erectile dysfunction, like vasectomy versus tubal ligation, it's very, very clearly like a gender bias. That leads to OBGYNs who are seeing a lot of patients. Prenatal care, they get one payment for the entire pregnancy, 10 months of pregnancy, every single visit, the delivery and postpartum visit is one payment. That is sometimes less than what the anesthesiologist gets for the epidural. So OBGYNs, and a lot of you probably, you know, seen in the office, they're seeing like 40 patients, like 30 patients a day, 5-10 minutes with each one. There's no way to go over all of these problems in like such a short time. So then they're like, look, I don't have time for this. Like, here's a brochure. Like, you know, I don't know what to do with your problem. Like, you know, they may not have done an endometriosis surgery for like some of their training, so they don't feel comfortable with it, so they're not going to recommend it. You know, so it's a whole system problem that's kind of set up to fail, you know, and to make the patient have to then be like, where do I go now? And that's why there's such a delay for things like endo and all of that.
So my question was going to be about the insurance system itself, because my surgeon actually did mention that she's reimbursed less. I had a colorectal surgeon and a urologist in the room, as well as the anesthesiologist.
Oh,
And her reimbursement is
A
like
fraction.
third
A
of
fraction.
what they're getting. That guy was in there for like 10 minutes.
Yeah.
And
oh yeah.
so
Yeah,
it
that
led me
happens.
to ask her, and because I had initiated a conversation, but it would led me to ask her in general, for women's health, I thought it was just like my specific condition, but it seemed like for women's health in general, is there a space for advocacy within the totality at the insurance level, because I feel like we almost have to climb the ladder of like start here in this room and then go to the individual health systems and say, this is what we want, and then the health systems go to the payers and say. Is it even worth it?
Endometriosis, like there's a documentary called Below the Belt.
I did.
And then, so Orrin Hatch, the senator, his granddaughter had endometriosis and was like, really struggling. And this is where you finally get like politicians who are like, oh, this is really serious. Like, I understand now. Like, like this is a bad disease and it really hurts people because I actually saw someone I know and love have this problem. Unfortunately, like it's gonna have to be like that where you have to really like appeal to, of course I can. Appeal to people and show the human side of this. And so endometriosis, for instance, like I and most other endometriosis specialists have moved out of network because there's just no way that you can't stay open. Like I tried every type of practice. I was in academics, I was in, employed. Like you can't keep the doors open because if you give the patient an hour, which is what they need, like, you're supposed to have seen 5 patients during that time to keep it running. And like, so so people are either employed in academics and the hospital takes a loss. They take a loss in the time that people are spending on endometriosis surgeries. And they're just like, well, maybe we'll make it up on like the MRIs, the imaging studies that you ordered for that patient. Because the radiologist gets reimbursed, but the gynecologist. So there needs to be a lot of advocacy and awareness around all of this and why it's.
Dr. Michaels, isn't the same with pediatrics? So my understanding is any specialty, if you put pediatric in front of it, you get paid less.
Oh, yeah, every specialty.
Pediatric cardiology,
Yeah.
pediatric surgery,
Yeah.
pediatric endocrinology, just get paid less.
Is that connected to women's health in any way, just because we are the source of said child?
I don't know. Primary care in general
Yeah.
is our primary care people are among the lowest paid.
That's
But
why primary care, mental health, and physical therapy also going to out of network, like direct pay, like, because they're just like, we can't stay open. That's why it's so hard to get a PCP right now. Like they found to. Yeah, or just because there's somebody's waiting on
Yeah.
Well, did you still have a question or me? Yeah, it was like 20 minutes ago, I'm sorry.
Everything's
You covered.
What's the intersection between your practice of endometriosis and versus fibroid care?
Overlaps a lot.
And what are your thoughts on when other non-specialist guides recommend the urinary embolizations?
Yeah.
What's your
So fibroids, for those who don't know, fibroids are very common. They're benign, non-cancerous tumors of the uterus, and they're super common. So if you were to do an ultrasound on like every woman, you would find them in like 7% of white women, 8% of black women, up to that many people. So they're very common in and of themselves, but they can cause like really bad pain and really bad bleeding, and because they can get huge, they can push on your bladder, cause like other, we call them bulk symptoms. So it depends on what you're treating, it depends on how big they are, it depends on what your thoughts are on fertility. So we have to ask all the questions about, do you want to get pregnant in the future? If so, you probably shouldn't do an embolization because that's blocking the blood flow to the uterus. It could impact future like placenta and fetus and stuff. So, but there are a lot of different options. There's a bigger point, there's a whole chapter on fibroids in there. There are a few more options than there used to be. There is almost no groundbreaking new science in women's health, I will say, except in recently, Dr. Lee was involved, the new medications for menopause, Vioza, which is a non-hormonal method for hot flashes, and there's new medications for fibroids that decrease bleeding, and then also new procedures where we can use energy to destroy the fibroids. So like very few like new things, but those are like the technological advances. So there are a few more things we can offer now. So we just actually started offering Acessa, which is the radio frequency ablation. So myself and the other specialists at Bryn Mawr, the first in Pennsylvania. So that's exciting. But embolizations are good for someone who wants to keep their uterus, doesn't want to get pregnant in the future, and certain locations of fibroids. We don't do them, they're done by radiologists. So if you're interested, we send people to do a consult with a radiologist who do them. But definitely, there are options. I thought you were gonna say if someone tells you to get a hysterectomy, because that used to be the default, was like if you had a fibroid, they just took your whole uterus out. Which is still, the way to get rid of them all, but not everybody wants hysterectomies.
I guess like my thinking, my follow up with You get a lot of refractory cases from failed.
Yeah, everything where you keep a uterus and just destroy a fibroid or try and remove it in some way, they can just grow back. So we always tell people, the downside of everything except hysterectomy is the fibroids can just grow again. So for our surgeries where we cut them out, we quote like a 50% will need another thing in the future. So it's pretty common for them to grow again. But it's different if you're like 49, you're almost at menopause, it's very different than someone that's like 27 and it's gonna just come back.
I also had endometriosis. I was diagnosed back in 21, so I've been dealing with it for at least like 14, 15 years, and I've had 3 surgeries for it, and I feel very lucky that I was able to find someone that knew about it. I mean, a relatively younger age. I was in college at the time, so that's great. My mom had really bad back pain with her periods. I just assumed my really bad back pain was
She had it too.
her. Yeah.
And it runs in families, so it often is the family lore that like everyone just has bad periods. And so it's always this way, I'll tell you. Everyone had bad periods. There were mysterious hysterectomies that no one knew why they had them. And then also people had trouble getting pregnant. So it'd be like, everyone in my family had trouble getting pregnant, they had miscarriages, they had a hysterectomy, no one knew why, and they had really bad periods. They had it.
But they didn't talk about it.
But they didn't talk about it.
Yeah.
So, or the doctor just didn't tell them. So that's usually the family lore, and it runs in the family, so like everyone has the same story.
Right.
Unfortunately,
Yeah. So, I mean, I had my first diagnostic surgery like shortly after I had tried to figure out what was going on with all of these painful periods, like to the point that I was on my clinicals and I couldn't stand up. So, but then once I found my surgeon and I was with him for a while, like things were fine. I would keep an OBGYN just for my regular stuff. And, cause I was back and forth from college, he's like 2 hours away. So anyways, I moved to Philly and now trying to find a new OBGYN. I've now gone through like 3 different OBs because, you know, I've been gaslit multiple times. Even my latest one, which I was like, oh, this should be easy. I live in Philadelphia. There's a plethora of OBGYNs. They should all be educated.
Yeah.
And you go on to like Jefferson and Penn's website and it's like, oh yeah, we cover all of these things. But I go to this, you know, OBGYN and she's like, you know, you're like my worst case that I've ever had. And I'm like, really? I'm a grade 2 endometriosis. And like my pain, I don't think is that
Not
bad.
that bad.
Compared to many people that I know or that are like within my endo circle.
Yeah.
So I guess my question is like, I still have my surgeon. I drive like 2.5 hours to go see him, but I actually think you might know.
Yeah.
But anyway, my question is, how do you see like the healthcare field changing to kind of fix this problem?
Yeah, I mean, there's been a movement for many years to separate the OB and the GYN. Because
Yeah.
it kind of doesn't make sense to have them all be one field. They're very different. Like, so, you know, people have been kind of pushing that for years, like years and years, and nothing has kind of changed. And so I think there's one program, I think, in the country that has actually, for the residents, split people into tracks. So that they are tracked to like surgical GYN, like pelvic pain, like all of these issues, and then the obstetrics. So I think it is too, just because like, you know, OBGYN is like a huge field, like there's so many things that they have to, you know, it's like primary care. It's like there's so many things that they have to kind of know that it's inevitable that there's going to be huge areas that be like, I just don't know this very well at all. And that then becomes, well, am I familiar with it? It's that you are unusual, which is not the case.
Yeah, that's
so,
what she
yeah.
literally told me, and I was
Yeah.
like,
I can tell
you to get on the block.
Yeah,
I
can
am
tell
not unusual.
How many people, endo, PCOS, and PMDD, like they could not be more classic things, like any medical student should diagnose these, but that people are like, I've been treated like a medical mystery. I'm like, within like 10 seconds, I'm like, you have PCOS. It's like, couldn't be simpler. But it's because, like I said, if someone doesn't see it that often and, you know, they're like, this is mysterious to me, they can't figure out what's going on, and then they can't kind of get you down the right treatment path. So I do think that, again, in a perfect world where we completely overhaul all of our medical system, I do think that it needs to be more specialized. There needs to be a lot more funding for, you know, the reimbursements and all of that stuff so that we can have more time to actually listen to patients and not just be like, that sounds crazy, you know, your time is up. You know, all of that. So it does end up with a lot of people then driving long distances to go to a specialist that they know and trust. You know, and we need to train more people too. We need to train more specialists.
Yeah. I would say a piggyback as well, shared experience here.
Yeah.
Even though we have a chronic condition, we are not in any sort of maintenance program with a physician. Where like I also have thyroid issues. I am in a maintenance program with my endometriosis, but it's like we've done the surgery, come back with the pain return.
Oh, I tell people all the
But-
time, and there are some surgeons who only do the surgery and then they're like, well, I'll never see you again. I'm like, no, I'm like, you want to see the person, just like you said, I want to kind of keep in touch and make sure
Yeah.
that, so I do annual exams, like a lot of surgeons like think that they're like, I'm
Yeah, I
above
was
annuals. I'm like,
referring
I
back to-
love annuals. I'm like, let's just see how you're doing, make sure you're okay, like we're, you know, catch something before it's been another 5 years and you're like in debilitating pain again. So I think that's important.
So you're in concierge now. Well, how is that different from the regular healthcare system?
So I call it's out of network, meaning that I'm not contracted with the insurances, so people, you know, pay when they come, but a lot of people don't know this, you have out of network benefits with your insurance, like most PPOs, you actually get reimbursed to see out of network doctors, it's just that we don't have a direct contract with them. So there's nuances, like, sometimes people have like a high deductible to see an out of network provider, so you have to meet that before they'll cover it, but oftentimes people like, you know, like, if it's not too bad, like a lot of people have very small deductible or no deductible, and then it'll cover like 60% of the cost, you just get reimbursed by your insurance. So, so that's why it, you know, it makes it easier for us to be like, we can set parameters, we can see if you're a longer time, like, you know, and then we just ask the insurance company to cover that. Which weirdly they will when you're not in the system, but they won't if you're in the system, so. Trust me. A lot of the men endo specialists, I will say, employ like legal teams to just fight it. They're just like, I'm just gonna charge a huge amount, I'm just gonna fight the insurance company until they pay me what I asked them to, and I'm like, that's too much trouble for me, but that's what a lot of the men endometriosis surgeons will do, they literally have a legal team, they're just like, I just go after the insurance company. That's every single case.
This is
They-
reaffirming that my advocacy is not so much as a patient for other patients. It's taking the machine back.
Yeah, it's terrible, but yeah, but we're gonna fix it, we're changing this. Yeah.
I have a question, maybe for you, maybe for other people in the room. How do you recommend that patients, when they have these chronic medical conditions and they have to miss work, how do they go about telling that to their employer? Like, I've told patients, like, I'll write you a note, but then I'm like, good luck. Like, I don't know how they.
So my approach is actually to try and make the symptom go away. So I don't write for the just, you know, out of work and stuff like that, because if it's like painful periods, I'm like, I'm pretty sure you have endo, we're gonna get rid of the pain. You know, and then for menopause, like hopefully we can find treatments for the symptoms so that you know, aren't having to kind of call out and stuff. So my approach has always been like, let's just figure out if there's a way that we can kind of get to the problem, solve the symptom, and then make it so that you can do what you need to do. You know, so, but, you know, I tell people, like, if you need it, like for, you know, post-op, like, it's just like anything else. Like, I think the employer shouldn't even really need to like kind of dig too deep. Like if the doctor fills out a form and says there's a medical code, just be like, here you go. Just like as if you'd like sprained your ankle, you know, just be like.
I usually write, contact me if you have any questions.
Oh.
And they never do.
Yeah. If you got like all the wisdom, I love it. You're just like, so we make it work. Like, that's actually a great strategy.
Yeah. So what I went with is I have a chronic health issue and I just need to take some time. And just left it there. And I was like, I dare you to ask a question.
Oftentimes when they see the gynecology on there, they want no part of it. This is long before they don't wanna,
Just like, I'm sick.
yeah,
You know, like.
they're just like a doctor. The HR is just like doctor note. FMLA form, you know, whatever. That's true.
Yeah, I was gonna say, I have loved the past few years watching your social media videos, so thank you so much for some. I've shared them with my children.
We knew each other because our kids were in preschool. Before TikTok.
To you, and then here you are doing this wonderful work, and I actually needed some stimulation, and I was like, this is fantastic, because not only was it educational, but you advocate, but what I loved is I was always laughing, right, and I still do, and so, and you always have, like, I'm picturing you now with like, thing, like, studies behind you, and pictures of fallopian tubes and things, like, I would love to know, and I can't wait to read it, how, you know, does that humor come into the book? And if so, how do you do it?
Yeah, you know what's funny? So my editor made me take out a lot of the humor, like the original. I don't know if you've read Tina Fey's Bossy Pants. It was almost like that. It was literally just like a funny picture of her making like a funny face, like, oh, you know, like, and so I had little things like that. And then the editor, I think, wanted a little bit more of like, it's a serious book and stuff. So she kind of took out my funny pictures and things. So I was like, okay. I will say the dedication, it used to be, to everyone whose health has suffered because of the fucking patriarchy, you're seen, you are believed, and you deserve change. And so she made me take out the effing. And I even was like, can I do F dash dash dash? Can I do like, you know, like exclamation point asterisk or whatever, like something? And she's like, no. She's like, and I, to be fair, like I'm like, she's the one who's in like, you know, a big 5 publishing editor or whatever. She knows. Yeah.
2 versions of
I was joking, but kind of serious. I'm like, maybe I make the version for like, you know, college students, and it's like a little bit funnier and stuff like that. So I think she was going for like, this is like a serious like women's health book. So we had to kind of tone down. But you know, I put a plenty of the like crazy fact, like many people didn't realize this, but it really blows their minds. So I tried to kind of keep some of like the it's interesting. It's not just like, here's a bunch of dry facts about like, you know, statistics. But just to say like, you know, hopefully it makes it come alive a little bit, like, you know, and a lot of people, even like the, you know, in describing the pelvic floor, they're like, what? I had no idea that there's muscles there. You know, just to make it engaging and interesting. And, you know, again, if I had my druthers, it would be a lot more just like kind of like have the humor, but you know, I take that, and then what I did when I sign books, when I go to bookstores and stuff like that, I ask the bookseller, and I did this obviously for Ellen and Narbrook, because I'm like, do you mind if I write something in there? And like they're like, yeah, do it. So you know, and I post on social media, I'm like, special version, and then they know they can go get it there. So I did that in English too. I'm like, special versions, Overstones, Piccadilly, like whatever. But yeah, again, if I had my druthers, I would have made it a little bit like kind of like more my personal.
Do you have it in audio
Yes.
format? And are you the reader?
I narrated it. So I made a video. I had no clue how any of this worked. I don't listen to audiobooks. Apparently now nonfiction is huge in audiobook, because people are like, I'm commuting, I'm cleaning my house, I just put something I want to learn. So they didn't audition me, but I had to talk with the producer to make sure that they felt like I could do it. They're like, yeah, we've seen your videos, we know you can speak, it's be great. It was very interesting. If you guys are audiobook fans, it takes a lot of work. It took 3 weeks of recording to get 8 hours, 12 hours or something like that of final footage. They record, they said, even for professional narrators, twice as much footage, and then they edit it down to like the perfect version. And so it would be like little things, like just the way that you like phrase something. They're like, well, can you actually like take the breath like in the middle of the sentence so you don't like sound too breathy when you're like gasping for air? So literally I had a director in an earpiece, I had a sound engineer. So it was very stressful at first, because they would interrupt me after every 2 sentences, be like, could you do that again? So, but then I got it and I felt great, and they were so complimentary, like, you're natural, and I was like, I'm gonna become a professional narrator. Yeah, it was fascinating, and it made me appreciate like there's Rosamund Pike narrated some science fiction book that like the final audiobook is like, it's like 30 hours. So she must have been narrating for like months, like just recording and all those crazy names, like the hard to pronounce. I couldn't pronounce certain medical names. I realized I was pronouncing certain medications wrong. They Googled it to make sure I was pronouncing it right. I think you're actually pronouncing it wrong. I'm like, no, I think that. But it was fascinating. It was very, it was a fun exercise, because sometimes like medical books, it gets kind of boring, and you have to kind of get it to be a little bit more engaging. So it's not just like a whole list of symptoms, and there's a lot of lists in the book. So if anybody who, you know, please buy the physical book from Ellen today, but also get a copy on Audible. No, but it was very fun to record it. So this is me.
All right, here's the postmenopausal question.
Yeah.
Is what care do postmenopausal women need in terms of gynecologic health? Like, do we need pap smears as often as we used to? What happens?
Yeah, we still tell people, the pap smear guidelines confuse a lot of people because they hear come back like 3 to 5 years, stop coming, you don't have to get them after you're 65, which is true. So if you get to 65, you've been getting paps regularly, they've always been fine, you haven't had pre-cancer, that's when we offer to stop them. But people think that means don't come back at all, or don't see your gynecologist except for every 5 years. We say you're much more than a cervix. So, talking about sexual health, vaginal health, bladder health, bone health, exercise, metabolism, we should still see you every year because of all those things. Like I said, exercise needs change, nutritional needs change. We're talking about, protein and, maintaining muscle, and again, sexual health is a big thing. So, both for preventative care screening, your cancer screenings, your mammograms, then your like just overall health stuff, your GYN health stuff, and then, like I said, the PAP is just like one part of that. So we still say come every year.
It's interesting because Medicare only covers
every 2 years.
every 2 years.
Yeah, I know. We come up with excuses. So you can see the doctor, it's
For
just called problem
for
visits.
diagnostic.
Yeah, exactly. So the regular checkups, they only cover every 2 years, but we can see you for anything. So if you have like, say like, vaginal, dryness issues or UTIs or whatever, we can see you for that problem. We just call it a problem visit instead of the annual. So you definitely can and should be seen if you're having issues between.
So can you talk a little bit about weight management during menopause?
Yes, it's big. Yeah.
And how do you find resources? I woke up one morning with a thinner tube of fat around my middle.
Essential obesity. I found out, I was like,
And they kind
I'm 45, and I'm like, what?
I know, like, what, you've got WTF, right? And I had a dietitian tell me that, it was all in my head, and I just need to exercise more and eat more salad.
Oh, no, yeah, so that's been a big conversation piece. So in addition to menopause in the moment, the menopausal weight gain has been getting a lot of news. And so, yeah, people tend to, metabolism is slowing, you get a little bit more what we call central obesity, which is, you get the fat that's like right here. Some of it's like internal, it's like not, you can't like crunch it away. It's like inside your abdomen. So this is where like I was saying, like you have to kind of change some of the things you're doing, both in terms of the exercise and also in terms of what you're eating. So protein and fiber. So a lot of people don't get enough protein or fiber, and so in menopause you have to kind of like focus on that. Also because you're losing muscle mass. So problem with the weight gain is as time goes on, you're like losing muscle mass, and so the muscles usually burn more calories. So then like that's why people are like, why I'm doing the same things, I'm eating the same things, suddenly I'm gaining more weight. So you have to like, focus on strength training, like a couple of times a week, try and do some sort of lifting, like, and I can tell you all of this stuff like better than I can. But strength training, protein intake to build the muscle, and you do have to sometimes see the dietitian and tweak some of the glycemic stuff, like the glucose kind of stuff. And then exercise-wise, in addition to strength training, like doing more kind of like intervals, like high intensity intervals, like to kind of rev your metabolism a little bit. Sometimes people will like walk for like an hour. You actually need to kind of like do a little bit more kind of like shorter times for like higher intensity and stuff, or like mix it up too.
And also just where it is.
And sometimes like the HRT might not
I've done stuff.
Yeah.
I've lived a life.
Yeah.
So I'm curious, can you talk a little bit about like what you talked about on like getting pregnant and fertility? 'Cause
Yeah.
I also feel like that's a topic. I'm lucky to have my sister for questions, but like you spend your whole life trying not to get
Preventive,
pregnant.
yes.
And like one day you're like, all right, I want
How
to
do
do
I do
this.
this? Yeah.
And then I'm like, my husband's asking me questions that I don't know and
Yeah.
trying to explain like ovulation or things. And I'm like, text my sister, but I feel like it's a weird thing that people also don't talk about until they get pregnant.
So this is where, again, I had this revelation, I was doing a podcast that, when we do like sex ed and all of that, it's all about preventing bad things. It's not about achieving the good things. So it's about preventing unwanted pregnancy. It's about preventing STIs. It's not about how to get pregnant when you want to. It's not about having a fulfilling sex life. So all of the good things are completely left out of the conversation. And then people are like, what do I do now? So in the book, I have a couple of things that, again, some of the fun facts about, you see on TV, I'm ovulating, now's the time to have sex. that's actually too late. So like the ovulation testing that you can do, it's not actually tell you that you're ovulating. It measures a hormone that goes up before you ovulate. That's actually the ideal time to give the sperm time to get to the egg. Egg only lives for like, 1 or 2 days or something, so.
12 to 24 hours.
I was about to say, yes, look at that, exactly. So, if you have sex when you're ovulating, by the time the sperm actually get there, it's actually already kind of too late. So just, tracking your cycles, people will start doing like things like the basal body temperatures and stuff, just to kind of get a general sense of, when you might be ovulating, the ovulation hits. And then trying to kind of time intercourse around those times. And fertility doctors will tell you, it's not you have to have like sex every single day. It's not sustainable. If you can do every other day, sperm lives for up to 5 days. So you don't want to deplete the sperm too much. So every other day around that window when you're ovulating. And then you tell people if you've been trying for, in earnest for more than 12 months if you're under 35. Or 6 months if you're over 35, or if you're in your 40s right away, basically, to get your fertility testing, see your fertility specialist, just to,
Or if there's something obvious, like you're not having regular periods.
Yeah.
And
So
just
yeah,
like
if you're
a
skipping
breakdown.
periods, you're having painful periods, like there could be something else going on, then right away.
Yeah, I'm curious, it might be more your field too, but like, so just, I know you read back with like 20% of people the first time, but there's no way for you to really like know, it's just all random.
Human fertility is about 20% for ovulatory cycles. They only take sex ed, they make you think you have sex one time.
Yeah,
Three
It's just
STIs.
someone.
But
That's
it's not-
scare tactic.
That's not what, put 20% in 1 month, 3 months, that's 50%. And in 6
Oh, it's
months,
like-
that's 70%. So I tell people it's in 6 months, there's a 70% chance you would be pregnant. There's 30, somebody at the end of it.
Exactly.
But I really should see a reproductive endocrinologist, because there's a lot of things that could be going. It could be your husband's sperm count, it could be a tubal blockage or something. There's no way. People focus so much on ovulation. Am I ovulating at the right time? Have I had sex at the right time? A lot of times it has nothing to do with it.
I'll tell you, there was one, I'm laughing because it's such a crazy story. When I was a resident, I was on my fertility rotation, and I was just sitting in on a consult, and the fertility doctor did the whole beautiful consult, and he was talking the workup, and like checking the tubes and checking the sperm, the semen analysis, and like the hormones and all this stuff, and it was like yes, and he had like a whole PowerPoint, and it was great. And then when he was telling the woman, like, you're gonna do all these tests, and he told the man, all you need to do is give us a semen sample, and the man was like, what does that mean? And he was like, like you ejaculate, we take a semen sample, and he's like, the man had never ejaculated before. He did not know what that meant. So they were having sex, he never had ejaculated, and he just, again, this is the importance of sex ed. And so we literally had on this entire fertility, like blood testing, and so I always tell people, and ever since then, whenever I change residents, I'm like, don't assume. Like always ask about all these things, because sometimes they're just like one thing. Like I've had so many fertility doctors tell me they've had patients who had severe vaginismus. They couldn't even have intercourse. They were having sex externally and thinking that some of the sperm was getting in, and they were just like, why am I not getting
Or
pregnant?
they're using the wrong orifice.
Right, yeah.
Yes.
Yes.
I've heard of that.
So we always tell people, you can't assume, like sometimes like it seems like there's something going wrong. It's not that there's something physically wrong, it's just that there's some misinformation. So that, again, from the beginning, I was like, I've never made an assumption about let's figure out what's really happening.
I had a patient who's like, oh, I have to have my IUD taken out for me to get pregnant.
Yes. I had a patient like that too, who came in for infertility. I'm like, it says you have an IUD in. She's like, what do you mean? I'm like, they put an IUD in, that is a pregnancy prevention device. And she's like, oh. So she's been trying to get pregnant with the IUD. So much. Again, like the importance of everybody educating themselves about their bodies, and also not just women, but men educating themselves about how pregnancy works and all this stuff. I was saying that sometimes like they split the kids into the boys and the girls. Everybody needs to know everything. Like you need to know how the other side works and how all of it works. So, those of your parents, make sure open conversation with your kids so that they understand how all of this stuff works.
I hate to break up the
I
party.
know, I was
Thank
just
you.
saying.
Good last little tidbit.
Amazing.
Kept us going for a little while. So high. I was telling you